Thank you so much, Dr. Luckenbaugh. That was really comprehensive, and I think you covered a lot of some of the questions that came in. So this is wonderful, and we have a little bit of time, so we will definitely get to the questions. I'm going to just go back to one of the first ones that we received. How fast typically does bladder cancer develop? And likewise, the transition from non-muscle invasive to muscle invasive in the case of those patients with high grade, what is the usual expectation as far as how quickly it can convert and become more aggressive?
That's a tough question. That's a great question. So we never know how long you have had it. It could have been in there for a long time and slowly growing. In people who have high grade disease and T1 disease, the evolution can be pretty quick. And so those people, we tend to be fairly aggressive. I know that when I give BCG to those patients, high grade T1 disease, I oftentimes, instead of looking after the BCG is done in my office, I have them go straight to the operating room and look with them under anesthesia and repeat biopsies right then and there to make sure that there is nothing there, to kind of save that time. There's no like crystal ball with how fast it can progress, but it certainly can be fast in some people, and some people can go years and years and nothing progresses, and then all of a sudden at year 4 of surveillance, all of a sudden, poof, they have a new tumor. And that's, I think, the frustrating thing for us and for patients.
Thank you so much. Yeah, that is very frustrating. So when you're doing regular routine cystoscopies, it's a pretty invasive procedure. How often do you recommend that people have cytology, urine cytology done to check for free floating cancer cells or things like that? And is it really something you do in conjunction with your cystoscopy, or do you can do that, kind of at a different time?
That's a great question. So for low-grade cancer, we do not do cytologies at all because the cytologies are usually negative. It only really works for high-grade cancer. And cytology is very good if it is positive. If it's positive, we can say there's probably something somewhere and we definitely should be looking. If it's negative, though, unfortunately, it's not very reliable. And so we usually do, for people with high grade, any type of high grade cancer, we do the cystoscopy and the cytology together. So in conjunction, there's not a great thing in the urine yet that can say, do we really need to have this cystoscopy? That's an area of research that is very ongoing and warranted because it is an invasive procedure. But right now, there's nothing that says, your urine looks okay, we won't do the cystoscopy this time. We have to do both.
Okay, great. That's very important information. Can you talk a little bit about those patients that have mixed grade, predominantly low grade, but maybe there's a few high grade? What is the concern there from your perspective as the urologist?
That's a frustrating question. I think that, our tough question as urologists is, do we treat those people as if they are low grade, or do we treat them as if they are high grade? And I think if it is a single time that they have a low grade and it says focal high grade, then I usually treat those people, if it's a small tumor, like they are low grade. But if it comes back, then I immediately switch to treating them as if it is high grade. And in those people, I do check a cytology when I look in their bladder, even though it was predominantly low grade, just to make sure that there isn't something else going on.
Mm-hmm. So when you go in and you do a TURBT, if there are multiple tumors, you would take all of the tumors that you could see out. So when they do the pathology report and that patient is seeing that pathology report, how do they summarize that? How do we understand if you've got all these different sizes and shapes of tumors and sometimes even different grades? How should a patient look at that pathology report, and how does that drive the recommendations of their individual urologist?
A good question. As urologists, me personally, we all do it differently. But if there are multiple tumors in different places, I like to make sure to separate them all out for the pathologist, because what we send the pathologist is kind of just a pile of junk, and it's not very easy for them to look at. So separating it out helps them do a really good job of looking at each individual spot. And then as the patient, I would take into account what is the, maybe this is negative of me, but what is the worst one or the highest grade one? And that is what we as urologists will be looking at and deciding our treatment based on. The multifocal, meaning multiple tumors, does kind of bump you into that either intermediate risk or high risk category and not the low risk category because there were multiple.
That's a great answer, really helpful. So let you take a sip of water and just think about, I know from a patient perspective, any TURP is too many TURPs, but is there such a thing as how many TURPs a patient can endure? What is the general rule of thumb before you begin to think, well, maybe we need to go on to something bigger and more heavy duty to attack this cancer, to treat this cancer?
That is tough. I think in low grade cancer, many patients can endure TURBTs indefinitely in low grade cancer. And sometimes even low grade cancers, now we look in the office and just burn them because it's been low grade for 5 years and we know it's low grade instead of taking people to the operating room. In high grade cancer, it isn't necessarily that we worry that their bladder can't handle it. It's just that we worry what will happen if they keep coming back. The more they come back, the more deep they're likely to go and the more likely they are to spread. So it isn't per se what your bladder is resilient and can handle it. It's more we just want to get to it before those cells start to creep outside.
That's a great answer. I appreciate that very much. So generally, you said that BCG is held in the bladder for about a half an hour before you void it out. Or no, I'm sorry, 2 hours, right?
Yes.
It was the cysview that's held in the bladder for half an hour before you look inside with the blue light cystoscopy. But BCG is in there for 2 hours. So I know that sometimes patients are sent home with BCG and asked to hold it for the 2 hours before they naturally void it out on their own. And then they have instructions for how to keep it safe and clean. But what about chemotherapy? Is a patient ever sent home with chemotherapy still in their bladder and expected to take care of that? Is that something that commonly happens, or is it different from chemo?
It does commonly happen. If it's the chemotherapy that we give right after the procedure, the single dose, oftentimes the patient's still waking up from anesthesia and everything, so they don't have to worry about that because we drain it out in the recovery area before they're ready to go home. But with something like gemcitabine, where you're getting it weekly for 6 weeks, we can also send you home with that chemotherapy in the bladder with similar guidelines on what needs to be done and how to do it.
This is awesome. This is really great information. I appreciate you doing this.
Yeah.
So, in general, and I know we're in the middle of a BCG shortage right now, but when patients are able to get BCG, are there long-term side effects that we see with the BCG installation inside the bladder?
Yeah, the BCG side effects are often cumulative, so they can get worse with the more BCG, unfortunately. Some people rarely have side effects at all, and that's great. And other people gradually start to develop side effects like frequency of urination, urgency of urination, burning. And some people very rarely can develop almost what we call an end-stage bladder from BCG, that it's so small and so contracted that they are urinating constantly. It's not common, but it's something that can happen. And so it's common as you're getting the BCG for things to kind of, they starts off okay, and then you slowly have side effects that are altered. And we can give medications to help with that. And we can also reduce the dose, and that sometimes can help with that as well.
Thank you very much. So given that the BCG shortage isn't getting any better anytime soon, I know you have a bigger practice at Vanderbilt, so I'm sure you're getting an adequate supply of BCG to treat your patients, or do you only have BCG for those patients who are in a clinical trial?
We right now have an adequate supply, but there have been times where we have kind of altered things, and we prioritize induction BCG in cases where we have to prioritize. We also prioritize people who have that high risk category bladder cancer in terms of getting maintenance therapy. And so that we haven't run into as many problems as in the community, fortunately, but it certainly is definitely out there. And we have strategies to kind of mitigate that if it happens.
Okay, there are a lot of people on this call, so I know not everybody is being seen in a large academic institution where they might have an adequate supply. So when they're being treated in their community, do you have a sense of what the community urologist is able to provide to them in lieu of BCG if they can't get it? What are some of the things that are being used in the community?
Gemcitabine is being used instead of BCG in the community, and some practices are reducing the dose and cutting the dosage in a third and splitting that third, the rest of the thirds amongst other patients to give some BCG rather than none. That is kind of my knowledge of the limited knowledge of what goes on. Yeah.
Yeah, I know you're at that nice ivory tower at Vanderbilt where they have a lot of great resources and not so much in the community. It makes it a little bit more challenging.
Yes.
Here's a particular question. How does the FISH test fit into monitoring?
That's a good question. I don't often use the FISH test. Some of it is a financial reimbursement thing, but I think that if we have doubts or questions about abnormalities in cells, specifically the cytology, getting the FISH can give additional information about whether there is an area of concern we should be focusing on, because sometimes the cytology can not be perfect, and FISH can help provide backup for the cytology. But I wouldn't use it as routine monitoring or routine testing or anything like that.
Well, there's been a lot of talk about some of the discomfort that goes along with both a cystoscopy and even for putting in the BCG. Does topical lidocaine help in your mind? When you see that, do you use that with patients if they have challenges with the cystoscopy or with the BCG installation? And does that impact both?
We do use it. I do not think it impacts things negatively at all. And if people have difficulty, we use it prior to CystView. Also, we use it prior to our cystoscopies, and it does not impact the effectiveness. That's like somewhat of a controversial topic, but I do not think it does.
Okay, great. So does the risk of recurrence and progression lessen in high-grade T1 cancers with the passage of time once it's successfully treated with the TURBT and the BCG?
Yes. It still exists, but one of the biggest predictors is after BCG. If we look the first time you've gotten it, if we look in your bladder and there is cancer back, that is one of the biggest predictors of future progression and future cancer coming back. So as we get further out, we feel better that it is less likely to happen, and that's why we decrease that frequency of cystoscopy and everything like that.
Great. Excellent. Good to know. Excellent to know. So there's a question that came in about the AUA, the American Urological Association treatment and monitoring protocols for high-grade bladder cancer seem to be based on experience with BCG. If you're having chemotherapy instilled, the gem and docetaxel, should the monitoring protocols be about the same as they would be for the BCG, or more aggressive, that more frequent scoping, or less aggressive? What's the general take on that? What is your thought?
Some of it is nuanced and provider specific, but I think if BCG hasn't worked, I tend to survey people a little more closely than the guidelines suggest, because BCG hasn't worked, and I want to make sure whatever subsequently is being used does work.
So if somebody were to have experienced something like a cystitis that came about from their BCG, what are their options for treatment?
So in terms of their cancer, they could still get BCG at reduced dose. In terms of their side effects, there are things that we can use, there's things over the counter, such as azo or pyridium that can be used to help reduce the burning. That can be given concurrently with BCG. There are things for bladder spasms that can be given, called like oxybutynin is an example, or mirabegron is another form that can be given to reduce bladder spasms. Some people have significant spasms when the BCG is instilled, and so there are people that we have them on long-term bladder spasm medication, but we also ask them to take an extra as needed dose before they come to get the BCG, so that that BCG can be held better. Sometimes in people who have spasms so severe, sometimes we leave a catheter in and send them home with it, and then they take it out once they've drained the BCG so that they're able to hold the medication in. So those are kind of some options, both to help continue to get BCG, but also for management of the symptoms from the BCG.
Sort of an interesting question. What size is considered a large tumor? And we're still going to stay in the non-muscle invasive. What would you consider a large tumor? And do you have any sense of the largest tumor that people have seen? And most of them, if you were thinking about the average tumor size, is usually what?
I would say the average tumor size is somewhere between 2 and 5 centimeters, about. The guidelines use 3 centimeters as the cutoff to move someone from the intermediate risk category to the high risk category. And some of that is based on research that has been done. But I would say 2 to 5 centimeters on average is average. And there are times where bladders are completely full of tumor. And those patients, I think one thing to keep in mind, if you are one of those patients, is that sometimes requires multiple trips to the operating room to get your bladder to be not completely full of tumor. And that's in part because we can only safely scrape for so long because of things that happen with fluid and everything like that.
Good. Need another break to take a quick sip of water? For asking, the questions are so good and they're just coming right in, and I just wanted to be sure you're ready to.
Yeah, absolutely. Thank you.
Good. So are there any contraindications for the practice of physical exercise after a TURBT or during intravesical therapies that you can recommend, or that you've seen patients have challenges with?
I usually tell people right after a TURBT, depending on the size, to take it easy in terms of no heavy lifting for greater than 10 pounds for about 48 hours. There's no data behind that, but I think it's your bladder is forming a scab, and so that straining or pressure can kind of burst the scab off and increase the risk of bleeding. But otherwise, I would say there's pretty limited physical activity restrictions, and during intravesical therapy, you can continue physical activity. You shouldn't have intercourse within about 48 to 72 hours of receiving it, but besides that, you can continue normal physical activity during the intravesical therapy.
Great. Okay, good. Does a evidence of a prostatic urethral carcinoma in situ, in addition to what might be in the bladder, affect the prognosis?
And it affects the prognosis. It affects the prognosis a little bit because carcinoma in situ in the urethra, the prostatic urethra, is a little harder to get rid of. It doesn't respond quite as well to the BCG because the BCG sits in your bladder, but it can't sit in the urethra tube. And so it doesn't have as much contact with the urethra tube as it does with the bladder. It's not to say that we don't try often to use it, but it just doesn't work quite as well as it does in the bladder.
Here's a medication specific question, and I'm not sure if you have the answer, but if you're taking tamsulosin, does that impact or affect BCG?
No, it does not. Not at all. Actually, a lot of people, we wind up, men specifically, putting them on it throughout the course of the treatment.
Okay, that's excellent. Thank you. Can BCG failure be due to steroid drugs being taken while having the infusions if you're on steroids?
It is a little bit dependent on how high of a dose of the steroids. If it's a low dose like daily prednisone kind of thing, typically not. But if you're on big doses of prednisone or big doses of steroids or big drugs that affect your immune system for arthritis or things like that, we may work with your rheumatologist or primary doctor to help adjust those, just to make sure to get the maximal effect of the BCG. It usually takes a pretty high dose though for it to not be effective.
I have two location questions. When the CIS is in the dome of the bladder, which is assumed to be the thinner part of the bladder, does that mean it's a higher risk of progression into the muscle?
No, the CIS so the dome of the bladder is slightly thinner, but it is, what really is important about the dome is it's the hardest to biopsy or scrape tumors off of because it can rupture like a water balloon. And so the real concern with stuff at the dome is on us, making sure that we get as deep as we can safely. It doesn't increase the risk of progression to muscle invasive though.
And if you have more than one tumor, but they're all clustered in the same location, the same area of the bladder, is that a good sign or maybe more of a risk? What's the risk there? It's
hard to say. We treat multiple tumors as multiple tumors and we associate it all the same. But the question is a good one because are there multiple tumors and they're just little satellites popped off of the main tumor? And that's why it's all clustered in one location? Possibly, but we don't have quite enough information about that to know.
Great. So we've got just a couple more questions and then you can take a deep breath, and it was definitely, this has been very informative. So what are the major differences between how US is incorporating blue light technology in terms of the standard of care, and maybe what you know about some of the things that are happening in some of our European neighbors, our partners across the sea? You know, blue light is there also. Are we seeing more of it in the United States, do you think, or?
I actually don't know. I think it's very practice and regional dependent because it does require specific equipment and specific scopes and specific towers. I don't know about how it's incorporated into European countries compared to here, but I think we don't use it up front here. We use it kind of as the next step usually.
Okay, this is kind of a timely question. When on immunotherapy like BCG, is there any concern about vaccinations for flu or for COVID? I know we've done a number of programs, but in your opinion?
I do not think so. I tell everyone they should go ahead and get their normal vaccinations and do all of that, regardless of the BCG or intravesical chemotherapy being administered.
Right. We certainly want to be able to keep you alive, and that would certainly be a big risk factor. So making sure that you're adequately protected from these other things.
Exactly.
Okay, and then the last question has to do with BCG. I know that it in some cases needs to be mixed under a hood because it's the attenuated virus and everything. But the question is, does it have to be administered in a negative pressure room with an N95 on?
The people who administer it generally do wear an N95 for their safety. They do not do it in a negative pressure room. It's administered in our normal clinic rooms in general, but they do wear gown, gloves, and an N95 and face shield to protect themselves.
Great. Well, I definitely think this has just been phenomenal. I'm going to end the Q&A period now.